Well, good evening, everyone, and welcome to our community town hall meeting tonight. Your health, your community, and COVID 19, where we hope to address community concerns about the COVID 19 vaccine. My name is Kathleen Kennedy. I am the Dean of the College of Pharmacy at Xavier University of Louisiana here in New Orleans. And I think we have an excellent panel uh, with us here tonight to answer your questions and to give you some more information about the COVID 19 vaccine. Our panelists include Dr. Keith Ferdinand, who is the Gerald S. Berenson Endowed Chair in Preventive Cardiology, Professor of Medicine at Tulane University School of Medicine. Dr. Lisa Morisi is a tenured associate professor in the Department of Microbiology and Immunology at Tulane University School of Medicine. Dr. Robert Gary is professor of microbiology and immunology and associate dean for the graduate program in biomedical sciences at Tulane Medical School. Christopher Sylvain is the owner of Best Life Pharmacy and Restaurant. He's also an instructor at Xavier University and the pastor of Faith Church. And then Dr. David Mushat. He is associate professor, section chief, Tulane Adult Infectious Disease. So we want to begin giving you a little background on our community town hall series. This event is supported by the Louisiana Community Engagement Alliance Against COVID-19 Disparities. It's a statewide initiative focused on understanding and addressing concerns of Louisianians about COVID-19, prevention and treatment to improve health in our vulnerable population. Given the recent state, national, and global focus on COVID-19 vaccines, our panelists will address key concerns expressed from our community partners. So as we begin, we know that we have gotten some questions from some of you, and we will handle those questions as we go through. As you have questions, you can enter those in the Q&A box, and we will try to answer those as well. So we begin with Dr. Ferdinand. As a practicing cardiologist in New Orleans, can you describe the common side effects of the vaccine to people so that they know what to expect and how to address them? Dr. Ferdinand.
Sure, let me make a few comments, and then at the same time, I will address that question. If we can go to the first slide in the beginning. I'm speaking not only as a member of the Tulane faculty and a community member, but also I'm working with the Governor's Task Force, the LA-CEAL, of course, and the Vaccine Action Collaborative. Let's go to the next slide. So here I am. I received my vaccine. My arm was a little sore, but that's about it. I felt fine. Some patients will get a fatigue sensation, a low-grade fever. Others may even have a flu-like syndrome. But this is not really a side effect or a complication. It's what we call a reactogenic effect. The immune system is revving up. It tends to be a little bit more with the second shot if you're doing the Pfizer vaccine, and it may be a little bit more profound in persons who are older. So this is something that we would expect. I would not consider this a side effect or complication. It's part and parcel of getting what can be potentially a vaccine that decreases hospitalization and even death from COVID-19. This is the first person who actually received the vaccine. It was a nurse, a Black nurse in New York City. And I say that because she specifically mentioned that she wanted people who look like her to overcome the barrier of accepting the vaccine. Next slide. We know that the disease itself, COVID-19, which is coronavirus infected disease, is disparate in terms of having higher rates of hospitalization and even death in older persons, Native Americans or American Indians, African Americans, and Hispanic Latinx populations. Next slide. And furthermore, when we look at specifically African Americans, the question becomes, why is that? Is it genetic? I don't think so. This is a response that I gave to the National Geographic when they asked me to reflect on why we were seeing this uptake in hospitalization and mortality in African Americans. And if you can point through the slide, just click through really quickly. One is persons who were working in essential jobs were getting more exposure to it. Persons who were using public transportations. If you remember early, we were doing testing in suburban malls. If you didn't have a car, you didn't get that early testing. You showed up at the emergency room in the throes of this disease when it was often late. And then finally, we have to face a true historical mistrust of Orthodox medicine by African Americans. I don't think that's because our population is somehow ill-informed. And indeed, if you go back even to the 1800s, it were the physicians who would go into the slave quarters and operate girls to learn how to hone their craft for surgery. Even in the next century, there were white hospitals, white wards, black wards. Most patients will mention the Tuskegee experiment, not even be able to articulate exactly what it was. When penicillin was found to be effective after World War II in 600 African American men in Alabama, it was withheld as a treatment. The study was basically to observe the effects of untreated syphilis. But this particular vaccine has been initiated by a multitude of investigators of various backgrounds, race, ethnicities. One of the lead investigators of the Moderna trial is Kismet Colbert. She's an African-American young female, 34 years of age, working with Dr. Fauci. The Pfizer-BioNTech is actually from Turkish immigrants who developed the platform for mRNA. So it's no longer just a case that this is another Tuskegee experiment on African Americans. I think that's misleading. And in fact, in the Tuskegee experiment, penicillin was withheld. If African Americans continue to be under utilizing of the vaccine, then we're not getting the benefits of what can be potentially life-saving. Next slide. So another thing that comes up is that the vaccine production was too quick. Some of our patients and the community members say this was warp speed. And I indeed agree with them. This idea of warp speed was a terrible name and implied rush job. But if you really look at the science behind this, the platform to develop these vaccines has gone on for years. And it was a better technology that was utilized that allowed us to have the messenger RNA vaccines released first the Pfizer and then the Moderna in mid-December. Next slide. President Trump, or I should have said former President Trump, did attempt to politicize the vaccine. That didn't help. And in fact, there was pushback from Pfizer, Moderna, and other leading drug companies. They actually had a joint statement and said that they would not use speed as the means of developing and put at risk safety. And indeed, when you look at the publicly available data, the safety and efficacy, the phase 3 studies, those are the big studies with over 70,000 patients. The vaccines do appear to be safe and effective. Next slide. So it's a misstatement. And I have friends at NIH, and I've told them very frankly that we should move away from this name warp speed. Next slide. The vaccines have been indeed the two that are available now, the Pfizer and the Moderna, tested in over 70,000 persons. Next slide. The effectiveness of both is approximately 94 to 95%. Next slide. In terms of the side effects, then I'll summarize. There don't appear to be any major safety concerns other than those persons who have a history of anaphylaxis to any particular component of the vaccine. But for most patients, other than the pain in the arm, you can get mild headaches, fatigue, but it appears to be safe and effective. And in subgroup analysis across gender, race, ethnicity, people with pre-existing medical conditions, I think the data are overwhelming that the vaccines are safe and effective. And I was a skeptic at first, but I think we're doing ourselves a disservice if we don't embrace the benefits of the vaccines, considering now that 3,000 to 4,000 persons are dying daily from COVID-19. It is now on a daily basis killing more than the 1,700 with heart disease and stroke and the 1,600 with cancer combined. More people are dying from COVID-19. Next slide. Specifically for the minority communities, we can always do better in our clinical trials, but there was a clear effort after a slow start to enroll more Black volunteers and other minorities in both the Moderna and the Pfizer studies. Next slide. And if we are concerned about vaccine safety, we should be. The data appear to be that it is safe and effective, but the other data is that COVID-19 not only kills, and I've mentioned daily, 3,000 to 4,000 persons more than the combination of heart disease and cancer, but it also disables. Anywhere from 8 to 10% of people have prolonged illnesses, the long haulers, and can battle symptoms related to COVID-19 for months, including neurologic symptoms or mental fog, chronic fatigue, respiratory symptoms. Next slide. One of the questions, we have some experts who are going to follow who work in virology and vaccines, and they're going to have to address this. This is from the CDC. One of the questions that are going to arise as we get more vaccines that come into play, will they be able to address some of these variants? Variations in virology are a normal finding, but there is a concern that if we don't address this pandemic in a more rapid and effective fashion, these variants will continue to grow and we will have more spread, more cases, and eventually more deaths. So while waiting to get additional vaccines and waiting for the federal government to assist the states with the application of the vaccines, next slide, it's important for us to go back. It's important for us to wear a mask, stay 6 feet apart, socially avoid crowds, and then get vaccinated when your time arrives. Okay, thank you.
Thank you, Dr. Ferdinand. And that was very interesting. And you pointed out one thing that we get a question about, and that is that sometimes when individuals have had COVID-19, they have prolonged illnesses afterwards. Can you explain what's going on there? And if they get the vaccine, will that prevent them from getting those illnesses?
Well, first of all, there's a lot that's unknown, and that's a little unsettling for people when doctors say that, but that's being honest. We do know that the vaccines, when they say 95% effective, we're talking about effective in preventing hospitalizations and death. You still can get infected. That's why you have to wear your mask, social distance, wash your hands. You still can get infected even after you get the vaccine. And remember, there's a window between the first dose and the second dose, 21 days for Pfizer, 28 days for Moderna. There's some effectiveness at that point, maybe 50% or so. But if you then are exposed before the second dose, or if you're exposed before you get the full immune response 10 to 14 days after the second dose, you still can get COVID-19. So the vaccines are very important, but it doesn't remove the need for the social mitigation. In terms of those persons who have the long-term symptoms, it's really a mixed bag. It could be a combination of subclinical infection or myocarditis of the heart. It could be subclinical persistent changes in respiratory function in the lungs. It could be subclinical changes in the neurologic function of the brain. And it doesn't necessarily mean that these are only persons who had severe types of COVID-19 infections. Many times these are persons who had milder forms, but they tend to linger. I think the take-home message is the following. COVID-19 kills more people on a daily basis than the combination of heart disease, stroke, and cancer. COVID-19 also causes long-term disability and symptoms lasting for months in anywhere from 8 to 10% of persons who are infected. The vaccines in the studies of over 70,000 persons and an observance of patients who don't have anaphylaxis, we're not talking about that one type of side effect, but in general, appear to be safe and effective. And I've laid up for nights trying to figure out how we're going to get out of this pandemic. I don't see another way other than social distancing, wearing a mask, washing our hands, and getting the vaccine when our time arrives.
Thank you very much. So we'll now move to our pharmacist. You know, the vaccines have been rolling out since December, and people are still having difficulty getting the vaccine. There's always a question about who's eligible and what do I do once I get this vaccine. So Chris, can you give us some information on that for those listening? Information about, how they can get it and who's eligible, those kinds of things.
Thank you, Dr. Kennedy. I appreciate that. Yeah, so we can go to the first slide of who gets it. Yeah, we can go right there. And we've already been through phase 1A, where healthcare workers, staff, residents, long-term care facilities, and emergency medical service and fire personnel have already been able to get it. And we're currently in phase 1B, tier 1. And that has 640,000 people in that group. And who's included there? People over 70 years old. We have ambulatory outpatient care personnel, schools of allied health students, residents, and staff, people being treated for end-stage renal disease. That's all about dialysis patients. And then we have home healthcare patients and personnel. Included with that is also dental providers and staff. Then we move on to phase 1C, and that would be people over the age of 65. And then essential workers, and we know they're the ones that's been so vulnerable throughout this, and then people with existing medical conditions. And so that's expected, hopefully early this year, and then distribution for the general public spring and summer. We've already heard that, President Biden has increased the purchases of vaccines, another 100 million from Pfizer and 100 million from Moderna. That would be able to literally vaccinate everybody. And the goal is to have it by the end of the summer. So we can go to that next slide. And that's just a repeat of the information that we just had of who gets it now. But again, and so who would get it next? 1B tier 2, essential government response personnel, judicial personnel, homeland security. That's another 318,000 people. That's the essential personnel. That would be food processing, agriculture workers, homeless shelter personnel, corrections officers and jailers, grocery store workers. Again, that's a more specific slide that dealt with the essential workers that we dealt with earlier. So we can move to the next slide. So where can I get the vaccine? Where can you get it? You can get it at 298 pharmacies. Literally, it's over 300 now because they've just added a few in the state of Louisiana. There are 50 of them in Orleans, Jefferson, and St. Bernard parishes, with 15 pharmacies in Baton Rouge. So what the state did was they shifted many of the vaccines toward the pharmacies because they're right in the community. They're available where people can reach them. But there are hospitals, obviously, that have them. All the LCMC hospitals have them, including UMC in Baton Rouge General. The Oshner hospitals have them. And that was an issue earlier concerning Oshner because some of their supply had shifted and they had to cancel their appointments. But they're starting to take care of those now. For many of the pharmacies, they had 100 doses that they were getting to people, and they ran out quickly. Many of them had waiting lists of 800 and 900 people. But the state is set to give more. The president is set to make sure that it's like a wartime move to make sure people are able to get it. It's not really expected until later at the end of March. Now, the key is it's all free for everybody, but they're asking for insurance information. To get that list of pharmacies, you can go to the Louisiana Health Department and just, search for that. And they'll have that list of pharmacies and literally all of the places where you can get the vaccine. You go to the next slide. Next slide. Good. Yeah. Okay, so what the state is doing is 58,000 weekly to be distributed at least for about the next 4 weeks. And the CDC doesn't know how many yet. They're planning. They're intending to be able to be more specific about how many the states are going to get, because that was the problem that the states had. They didn't know when they were going to even receive a shipment. and it was challenging being able to receive the shipment and then get it out because it had to be used in a certain amount of time. So what happens is that, Tulane Hospital is also administering as well. So that's about 339,000 have been vaccinated out of 900,000 currently in that first phase of that phase of 1B tier 1. So what that means is it's literally at that rate of 58,000 coming out. It'll take about maybe 10 weeks to finish this 1B tier 2. We're really not sure because it just depends upon supply. It depends upon people's receptivity as far as for getting the vaccine. Now we have to look at it. It's about 39 7-day average, about 39 deaths per week. So by the vaccine being delayed, the issues of the vaccine coming out, then you have to realize that's more deaths that can occur. And so just in Louisiana itself, if we average that out, you're looking at, almost 200 deaths that can happen because vaccines, we know, are effective to make sure that people are not only not getting very sick, but definitely not dying. So the Johnson & Johnson vaccine may help. Looking forward to that. It may come out soon. And truly, it's important that more supply comes through. Now, there's an organization called Christian Vaccine Access Coalition, christianvaccine.org. Later on, we expect that probably next week, where there's a team of health professionals and others that are attempting to find out who has vaccines and where you should be able to just go to that website. That should start up next week. And that'll be important for, because right now people have to call the pharmacies, you have to call the hospitals, you have to find out, are they making appointments or how long that it is? Because the information varies. It really, really does, because it's not enough supply. But once there's supply, then it'll be available everywhere. They expect to have mass vaccination centers. Now, again, it's important that people recognize, as Dr. Ferdinand just mentioned, that the vaccines are safe, they're effective. When we compare that to drugs themselves, all drugs have side effects, and that's what people have to understand. Drugs have side effects. And so when they think about the side effects and the issues associated with the vaccine, it's necessary that people realize comparably the vaccines are truly, truly safe and effective. So we look forward to people getting the word out in the community, community leaders letting people know that they have taken the vaccine, and it's important that we reach people so they know how to be safe and to prevent these deaths. And I think we're on our way. Thank you so much.
Great, thank you for that information. And it's really important to let people know where they can get the vaccine and how to sign up. And just to let you know that the federally qualified health clinics in the area are also providing vaccinations. We also at Tulane is providing vaccinations, particularly for allied health professionals and students. So those are other places where the vaccine can be obtained. So we really appreciate that. One question that we have is about what happens after the vaccine. And I know that Dr. Ferdinand stressed, wear masks, social distance, et cetera. What do you have to do those same things after you've received the vaccine, Chris?
Yes, that's controversial right now. As Dr. Ferdinand just mentioned, that we really, there are schools of thought that saying that after you receive the vaccine, people who are vaccinated already together, that they can feel that they're safe, because there is a risk. So it's not like there's not a risk at all. The concern is people that have been vaccinated still being able to transmit the virus to others that had not been vaccinated. And that is the concern right now. But once we achieve so-called herd immunity, then people would be able to be protected and move more towards a normal life, but not until that time, once the vaccine is suppressed so much in the community. But yes, it will be better. And then I think that it's important that people know once they've taken the vaccine, they not only will they be protected, but they're helping move the country towards herd immunity, where we can move more towards a normal life again.
Right. But it is important, though, after the vaccination, you still have to wear a mask.
You still have to
need
wear a mask.
practice social
Right.
distancing, wash your hands. All of those are still very important after the vaccine.
That's correct. Not
Thank
until
you very
you,
much for that
right, that's correct.
information. So I know that like I do, I look at the news and I hear all the numbers and what's going on. And we have a person who can provide us with great information about what all these numbers mean, who's dying, et cetera. And Dr. David Machat is going to provide us the state of COVID-19 in Louisiana. Dr. Machat.
Great. Thank you, Dr. Kennedy, for inviting me to do this evening. And I'd like also to thank our audience out there for tuning in tonight. Really appreciate it. So next slide, please. I'm going to kick this off with just kind of an overview of the scope of COVID in around the world, in Louisiana, and locally. So this is a dashboard from Johns Hopkins that summarizes what's going on around the world. And you can see up here in the left-hand corner that already there is over 100 million cases of proven COVID-19. And there's probably several times that number of people that have actually been infected. They just haven't gone for testing. So it's an enormous number of people. And it's hard to see it here, but about 26 million Americans have been diagnosed. And so we're about 2.5 times ahead of India, the second largest number. And again, this is only the known cases. There are probably maybe 2 times, maybe more Americans that have actually been infected. Sadly, the world has crossed the 2 million dead number here. Again, there's probably more people that have died from COVID. The US is approaching 450,000 people that have died from COVID. It's truly a horrific pandemic. And this is I'm just kind of building my case now for why it's going to be so important to get the vaccine. Next slide. So if you look at what's happening in the US and Louisiana here, you can see this graph of daily cases. The good news is that the daily case rate is going down. It's a fairly steep descent right here, which is good news. So the number of cases is down, and the number of hospitalizations is down, and the number of people dying is flat. If you look here in Louisiana, you can see that our numbers have gone down as well. There's a little bit of a plateau here. I'm hoping that's just a statistical aberration. Hopefully it'll keep going down, but it has been going down. So the number of cases is down, the number of deaths are down a little bit, and the number of hospitalizations are down, which is good because we hope to unburden our hospitals a bit so that hospitals can take care of all the other people that are sick with all the other conditions that people get. Next slide. So this is the New Orleans dashboard, and what you see here is you want to see green, or at least mostly yellow, and you can see that at least our infection rate now, that's a number of people that a person will infect on average if they have COVID, is less than 1, which is good, and our positive test rate is finally getting back below 5%. But the number of cases on a daily average and the percent of beds that are in use are still high and very worrisome. Next slide, please. This is the 7-day average, so daily case rate, new cases. You can see that we have come down. We may have sort of hit a plateau here, but the number of cases on a daily average has gone down significantly from the recent peak. Next slide. And this shows our daily numbers through yesterday. You can see that in New Orleans, there were 111 cases yesterday. So that has gone down, although it's plateaued a bit, only 2 deaths and 46 new COVID hospitalizations. So the numbers have gone down, but they may be plateauing. Next slide. If you look at Jefferson Parish, you can see here that as of yesterday, they had 281 new cases. But the good news is the number of cases is trending down, and their number of deaths per day is sort of plateaued. Next slide, please. Similar data for East Baton Rouge Parish. You can see that they had 136 cases on January 26th. The number of daily cases on the curve here is going down, thankfully. and the number of deaths appears to have plateaued, which is good news. Next slide. So let's turn then to COVID vaccines. So folks, I'm no mathematician, but let me walk you through this simple math that you could do in the back of a napkin. So basically, let's assume for the sake of argument, and I think this is pretty close, that maybe about 20% of us Americans are immune, either from getting the vaccine or from having had COVID. So what do we need to get to? Well, people that are much smarter than me say, probably we need to get to about 80% of people, 80, 75, 80, maybe 85%. Let's say 80% of Americans need to be immune for us to get to this thing called herd immunity. And once we get to herd immunity, we can get this pandemic behind us. We can get back to some degree of normalcy. So in my simple math, 80 minus 20 is 60. So 60% more Americans need to become immune. And that works out to almost 200 million Americans. It's a lot more people. And if you assume that on average, about 1 to 2% of people die from COVID, now it's higher in very old people, it's lower in young people, but let's say, roughly about 1 to 2%, that could be as many as 4 million more Americans that could die if we allow COVID-19 to ravage our population unchecked, without any prevention, without any vaccine. That's horrible. So on the other hand, if we vaccinate Americans, we could get that number down to thousands, tens, hundreds of thousands, tens of thousands, et cetera, much, much lower. So we could really prevent a lot of the death and the misery that our fellow Americans are suffering. So my answer based on this very simple math is yes, we desperately need vaccines as soon as possible to save lives and get us back to some degree of normalcy. Next slide, please. So it's a little hard to see this, but this is the CDC tracker that shows how many vaccines have been given in the US. And right now it's up to 47 million as of yesterday. That's, it's not bad. And about a little over 20 million people have actually gotten their first dose. But, 47 million out of a population of 330 million, it's still a relatively small percentage. We have a long way to go. Next slide, please. This is the vaccine rollout data for Louisiana. As of yesterday, you can see that about 7% of our fellow Louisianans have received or at least begun the vaccine series, a little over 300,000. So we still have a long way to go. And you can see this shows you where the vaccines, the sort of the numbers of vaccines that are given in different areas. You can see that Region 1, which is New Orleans and Jefferson Parish, have the largest number, but pretty good number up here in northern and central Louisiana. Next slide, please. So the good news is that in a year, we have over 60 vaccines in human trials. I'm not going to get into all the details here, but there are at least 8 vaccines that are in later stages of clinical trials. They have to be done in humans to show that they're effective and safe. And these are the 5 leading vaccine candidates that we're likely to be looking at in the next 6 months in the US. So we have the Pfizer and the Moderna. They both use the same mRNA platform. That's the basic construct of the vaccine. Then we have the AstraZeneca one that's being used in the United Kingdom, and the Johnson & Johnson or Janssen, and those use an adenovirus. That's a common virus that can cause mild infections in humans, and that's a slightly different way of making a vaccine. And then you also have the Novavax, which is using a protein. And I'll show you in just a minute where we are with those vaccines. So next slide, please. So this slide summarizes where we're at in the development of these vaccines. So the Pfizer vaccine is in use in the US, as is Moderna, as illustrated by the green bar. AstraZeneca is being used in the United Kingdom. Okay, that's their main vaccine. And, the FDA here in the US is reviewing their data. And hopefully this will be made available in the near future. Novavax is a little bit further behind. That has a little bit further to go. So it's not quite clear when we'll see that in the US. But the next one after the ones that we have is probably going to be the Johnson & Johnson. That's also referred to as the Janssen. That's the name of the subsidiary. And this one, we think the data may be coming out this coming week. It may be a press release It may be an early publication, I'm not sure, but there should be some data that actually tells us how effective it is in the human studies that have been done in the US and elsewhere. And so if that's the case, then the FDA will be looking at it very shortly, and we may see this vaccine roll out in the next couple of weeks. Next slide, please. So, a common question is, and a common concern, and it's a real concern, is was vaccine development rushed? I don't like to use the term rush because it sounds chaotic. It sounds haphazard. I think it's fair to say that vaccine development has been accelerated. And so this shows you how vaccines are normally rolled out. Usually what happens is they're studied in test tubes and then in animals, and then they're put into humans in phase 1 through phase 3 study. And this process takes years. But what they've done this time is they've overlapped some of these phases. Phase 1, 2, and 3 are all studies in humans, but they're overlapping them. So essentially, it's a much more efficient process. But the other thing that made a huge difference this time that's never been done before is that the United States government, in the form of BARDA and other agencies, has pumped over $25 billion into this research. And a lot of this was done to reduce the financial risk for these vaccine manufacturers, because normally a company making a vaccine is not going to ramp up production. They're not going to build the factories to make it until they know darn well that the thing works and is safe. They're going to wait until the very end of the studies. But what they've actually done is they started making these vaccines early before they got approval. So once they get approved, they're ready to hit the ground running. And I think this is really a brilliant move on the part of the U.S. and other countries to fund this early. It's very expensive at 26 billion, but it's nothing compared to the trillions of dollars that are being lost because of people being out of work, because of the effects on the economy, because of the effects on the healthcare system. So it's a really good investment. So I would say that it's been accelerated, but not rushed. And I think the next slide, that may be it for me. Thank you.
Great, thank you, Dr. Mashat. I'm sure all of us know someone who's had COVID, who's tested positive. And so the question is, are they immune? Do they still need to get the vaccine?
So the good news is if you had proven COVID, if you had that nasal test, with the PCR swab and they told you had it, it's more likely than not that you are immune, okay? You could get antibodies done. We're not exactly sure how to interpret those antibodies. So it's not entirely clear whether an antibody test that's positive is equal to protection. But the bottom line is if you've had COVID, you more likely than not are immune, but we don't know for sure. So as a result, we recommend that all Americans who are eligible get the vaccine regardless of whether or not they have COVID. If nothing else, if you get the vaccine, even though you had COVID a few months before, you will probably be even more immune. You'll have more protection. So yes, go ahead and get the vaccine as soon as you can.
Great, thank you. So the LA-CEAL team has gotten several questions about these vaccines. How do they work? What do they do? What do they not do? And so we have some experts who are going to tell us a little bit about that. So we're going to begin with Dr. Morisi and then Dr. Gary. So Dr. Morisi.
Thank you, Dr. Kennedy. I really appreciate the opportunity to talk with our audience tonight about the vaccines that are being made for COVID-19 and those that have been approved here in the United States, because I think there are a lot of misperceptions out there in the community that's being spread on social media and a lot of Facebooks. And so when we think about vaccines, what all of us are used to are sort of the annual flu shot that we get in our arm, or that the shots that we got as kids. And those are traditionally made by growing up large amounts of, in this case, a virus, and then inactivating that virus and injecting that intact virus into our muscle, or weakening that virus so that it can't cause disease, and then administering that weakened virus into our bodies so that our bodies can mount an immune response to it. But as you've heard, these vaccines that are being produced and made available to us to combat COVID are based on what's considered new technology. And that's because we've never had FDA licensed vaccines based on this technology in the past. But what I'd like for our audience to know is that these vaccines have been in development for decades. And so scientists and engineers have made improvements to these technologies over many, many years to get them to the point where they were ready to be deployed in the face of a pandemic, as we're facing right now. And so this schematic, it looks like it's a little hard to see on the screen, but what I just wanted to show you is I just wanted to break it down for you to explain what are these messenger RNA vaccines that Pfizer and Moderna have made available to us in the United States, and what are some of the ones that Dr. Mushat just mentioned, the AstraZeneca, Oxford, and the Johnson & Johnson Janssen's vaccine that we think will be approved, very shortly. And those are based on what are known as adenovirus vaccines. And so, if we use the comparison to the whole virus, which is, for example, the flu vaccine, where we inject whole inactivated flu virus into our arm, these vaccines basically take the instructions for making just a little piece of the the SARS-CoV-2 virus, which causes COVID-19. And the little piece of that virus is known as the spike protein. And it's the spike protein on the surface of the virus that allows that virus to attach to our cells and invade our bodies. And so the idea is if we can induce an immune response to that spike protein, in this case, antibodies, for example, or another component of the immune system called T cells, then we can train our bodies to recognize the virus and we can combat that virus. And so these technologies are known as basically nucleic acid technologies, where the messenger RNA is just a tiny snippet of information that's incorporated into a carrier, in this case, a lipid nanoparticle. And I know that's a fancy name, but basically all a lipid nanoparticle is a little tiny, tiny fat bubble. That's a really good way of thinking of it. And so what they do is they take the messenger RNA that has the instructions for making the spike protein, they put it into this little fat bubble, they inject it into our bodies. The fat bubble helps deliver the messenger RNA to our cells. Our cells recognize the messenger RNA because our cells use messenger RNA for our own proteins that we make for our own bodies. And they say, oh, here's a piece of messenger RNA, and it's telling me to make this spike protein. So the cells go about making the spike protein, and then some of that spike protein gets presented on the surface of our host cells, our body's own cells, so that our immune system can recognize it as foreign, something that's non-self, and again, mount an immune response to it. And that's all there is to it. And so the messenger RNA is really not that foreign. Our host cells make messenger RNA, again, to make our own proteins. For the adenovirus technology, it's very, very similar, except the adenovirus, as Dr. Mushat mentioned, is a weakened, basically virus that causes typically the common cold. And so in the case of AstraZeneca's vaccine, it's a chimpanzee virus. In the case of Johnson & Johnson, it's a human virus. But both of the viruses are modified so that they can't replicate in our bodies and they can't cause disease. So similar to that fat bubble that delivers the messenger RNA to our bodies, the virus delivers the information encoding the spike protein to our bodies so that we can induce an immune response. Next slide. So in terms of these messenger RNA-based vaccines, we have the Moderna and the Pfizer. And this slide is simply to show you that they're very, very similar. So the fact that there's a lot of people out there like, oh, should I get the Pfizer vaccine or should I get the Moderna vaccine? Which one's better? This is just a slide to show you that they're very similar. They both use the messenger RNA platform. They both use those little fat bubbles to deliver the messenger RNA to our cells. They're both given in 2 doses. Moderna's, the second dose is given 4 weeks later. Pfizer, the second dose is given 3 weeks later. The efficacy, so how well they reduce disease in the vaccinated population versus people who aren't vaccinated or received a control, placebo as it's called. 94% in the Moderna trial, 95% in the Pfizer trial. In terms of effectiveness across different ages, genders, and races, maybe there was some slightly reduced efficacy in people over 65 years of age with the Moderna, but it was from 94% to 86%. That's still terrific. Pfizer showed that it worked the same across all age groups, genders, and races, which is terrific. And Dr. Ferdinand showed you some data on, how the different genders and races and ages were included in those studies. And like all vaccines, yes, these vaccines do cause side effects, but they're mostly minor. Sore arm, fatigue, maybe a headache, maybe chills, some people have fever, but these are all minor side effects. And again, it's that your body is responding appropriately as it should to the vaccination. And you should feel good if you have minor side effects because it means your body's mounting an immune response. Next slide. So these adenovirus vaccines are not approved yet here in the United States, but I wanted to tell you a little bit about them in case they are approved. We do expect them and we're hopeful that they'll be approved in the near future. So again, they're called different things. The AstraZeneca one was called ChAdOx1. Again, it's that CH comes from chimpanzee. It's a chimpanzee virus naturally. And then the Johnson & Johnson is a human adenovirus. One of the differences between these two vaccines, and one of the things that we're excited about, is that the Janssen vaccine is given as a single dose. So unlike the messenger RNA vaccines, which require 2 doses, Johnson & Johnson is going with a single dose, and we're hopeful that that's going to provide as much protection as the messenger RNA vaccines. The AstraZeneca vaccine, you might have heard about in the media. There was some differences in efficacy depending on the population. There was a little bit of a screw up in the UK study where some of the people got half the original dose that they were intended to get, and they actually did better. And there's a scientific explanation for that. So we're not all that surprised by that. So they have to redo the trials and sort of optimize the dose. And we're very, very hopeful that once they do that, again, that these adenovirus platforms are going to give 90% or greater efficacy similar to the mRNA-based vaccines. And we don't have the efficacy data yet for Janssen's trial, but as Dr. Mushat mentioned, that we should get that very soon. Next slide, please. So I really, really want to emphasize this slide to the community. There is so much conspiracy theory and myths that are being spread on social media platforms, and they really sound scientific. And I've read some of them, and I'm like, wow, that's kind of scary. That sounds legit. But if you just take a few minutes to Google it, go onto the internet and ask the question, there will be numerous scientific articles that debunk these myths. So let me talk to you about a few of them real quick. So first of all, the fact that these vaccines are based on nucleic acid, mRNA, for example, it does not mean they're going to integrate into your DNA. There's no evidence for that. These adenovirus vectors that are being used cannot integrate into our genes. The mRNA is not the same thing as DNA. In fact, it doesn't even interact with our DNA. So I can tell you that there's no evidence and no likelihood that these vaccines will integrate into your DNA. In fact, once they're taken up by our cells and our cells make the spike protein, these mRNA platforms and adenoviruses are degraded. They can't replicate, they can't integrate into our DNA. So they're eliminated from the body. There's another one that's going around. The vaccines cause female infertility. There's no scientific evidence for that whatsoever. In fact, there were multiple women in the Pfizer who received the Pfizer vaccine who became pregnant. This is, again, a myth that's being spread on social media. There is a lot of talk about the use of fetal cells or tissues with these vaccines. And so I have here for you that the approved vaccines, so the messenger RNA vaccines that are being distributed and immunizing folks in the US right now, they were not made with any fetal cells or tissue. The reason that there's a lot of information on that on social media right now is because adenoviruses, which are the AstraZeneca and the Janssen vaccine technology, they use a fetal cell line to basically grow the adenovirus in. But that fetal cell line was derived 40 years ago. And so I can tell you that there were no fetuses harmed anytime recently for the purpose of making COVID vaccines. And if you have any concerns about receiving the adenovirus vaccine because of your beliefs or your religion, I would encourage you to talk to your faith leader about it because they have guidance on those issues. The vaccines also do not cause COVID-19. These are not live viruses. They cannot cause the disease. The vaccines do not carry microchips to track you. This was another one that was being spread. As you guys might imagine, a microchip is very, very tiny, but these nano-sized vaccines that we're using are 1,000 times smaller. A microchip would not even fit in the vaccine. And again, Dr. Mushat already addressed that these vaccines were not rushed. And I understand why people, may not want to be the first in line to get the vaccine. But what I can tell you is you're not the first in line. Millions and millions of people have received these vaccines. They are extremely safe as far as vaccines go. Next slide, please. And lastly, Dr. Mushat, explained that, the clinical trials, how they were done. The FDA, when they issued the emergency use authorization for these vaccines, they carefully review all of the safety data from the clinical trials, and they rely on an independent panel of experts who have no affiliation to these vaccines or these manufacturers to make recommendations to them. And so, you can trust that they are making that they have good judgment, and they are studying the data before they make the approval. And then after these vaccines are authorized, there are numerous mechanisms in place to track the safety of these vaccines. Okay, so the FDA is monitoring the safety, the CDC is monitoring the safety. If you get immunized or you've already been immunized, you might have gotten a card where you can report adverse events just on your smartphone. It's known as vSafe. And so the CDC has already said they've gotten 1 million people reporting on vSafe. I got the vaccine, I had a sore arm. These vaccines are safe. Millions of people have gotten them. The other thing I just want to leave you with is that most vaccines, if they have serious adverse events, you know it within 2 months. So if we look back on the history of vaccines, serious adverse events reveal themselves within 2 months. We're beyond that. We know these vaccines are safe. Thank you.
Great, thank you for that great information. I heard you talk about the vaccines, and I think one question that people ask, they have a friend who's gotten Moderna and the other one who's gotten Pfizer, and now we hear that one is coming out that'll be a 1 dose. Why is it, does someone need to wait for that, or should they get any vaccine that's available to them? Could you maybe speak to that a little bit?
Absolutely. So my first advice is don't wait. Take the first available vaccine that's made available to you. I can promise you that our independent panel of experts that's making those recommendations to the FDA, as well as the FDA, they're going to hold all vaccines to the same safety standards. And they're going to make sure that they all have a high enough efficacy to help us achieve herd immunity. And so, you hear about all these different platforms, and maybe there's some suspicion that one platform is going to be given to government officials, and another platform is going to be given to the rich and the elite, and then the rest of us are going to get stuck with the hand-me-down or the vaccine that's not as good or that's cheaper. But here's what I want you to know. Dr. Mushat explained that we're all in this together, and we have to achieve herd immunity. So it doesn't do anybody any good to give one select area of the population the good vaccine and the rest of us a bad vaccine, because it won't get us to herd immunity. We all need to be immunized with a highly effective and safe vaccine to get us there. So we're all in this together. We're all going to have access and should have access to the same safe and effective vaccines.
Great, thank you very much. So now, Dr. Gary, one of the things that we're hearing a lot about are these variants. And so can you give us some information about, what this means? Are they more deadly? They spread more rapidly? Can you give us any information on the variants that we're hearing about on the news?
Well, thank you, Dr. Kennedy, and thank you to the audience. So, yes, I have some news for you about the variants, and it's some good news. And but I also have a couple other pieces of good news. First of all, I'm the last one of these talks, and then we're going to get to the questions after I'm done. And the other piece of good news is I'm going to be shorter than some of the previous speakers. I only have 3 slides to show you about these variants. So let me get on to that news about the vaccine the variants and how they're impacting the vaccines. So the first variant that you've probably heard about in the news, because these variants are all over television and the newspapers and social media and the like. And there is, as Dr. Marisi said earlier, some, a lot of bad information out there on social media about COVID and the mutants and the vaccines, et cetera. So let me try to keep it, simple. This is the coronavirus, SARS-CoV-2, that causes this disease that we're all being faced with. And there are things about viruses that you should know. They do mutate, they change. Their genetic material is pretty simple. And when they replicate, they make mistakes. Now, our cells replicate and they make mistakes too sometimes, but we have mechanisms to correct those. Well, the viruses are just too simple for that. And when they get a mutation, sometimes it sticks. And sometimes that mutation makes the virus a little bit more fit and it replicates a little better, and you might see it start to appear more frequently. And that's what we're seeing with this so-called variant of concern. I'll call it by, its official virology name, B.1.1.7, but you can remember it because it first appeared in England or the United Kingdom, and that's the way most people will refer to it. Now, this variant has several of these mutations that I've talked about, and they all turn out to be, the most important ones at least, changes in that spike protein that you've also heard about a little bit earlier in the talk. And that's the, kind of magenta colored, purplish colored blob on the surface of the virus particle. You can see, it's sticking out on the left, and you can see it in cross section on the right. That's the viral protein that does all the work. And, that's also the viral protein that the virus uses to get into cells and start the whole replication. So that's why we put that spike protein in the vaccine. So we put it in the Moderna, the Pfizer, the adenovirus-based vaccines. We try to get that protein expressed, and then your body can recognize it, and then it comes back a little bit later. And if you get exposed to the virus, your immune system is all primed and ready to go. Now, the thing about these variants, and as I said again, I'll emphasize it again, we do expect that the virus is going to change somewhat. We expect that with the flu vaccines, that's why we have to change them up every couple of years or so. And it's happening with the coronavirus because it's infected almost 100 million people, and we expect it's going to change. So this variant of concern here, the one that was first detected in England or the United Kingdom, has 3 or 4 mutations. And I just highlighted one there. It's called N501Y. That's virologist talk there. It just helps us keep track of what changes are made. And I can tell you, this is a variant that you want to have if you're going to have one of these variants. And it was, in fact, recently found in New Orleans. And there are going to be more of these B1.1.7, the English variants, the UK variants popping up all over the country. And that's actually fairly good news because, this is the variant that's of least concern. So it's called a variant of concern. And I call this one the variant of least concern because even though it does transmit from person to person a little bit easier, we know that it's not more deadly. People don't die from this variant any more than they do from the variants that came before it. And we also know that your immune system is going to recognize it just about as well as the variants that came before. So it's what we call low immune escape. So if you're vaccinated or if you had the infection before, you're probably most likely going to be resistant to this B1.1.7 or the English variant. Now, the little piece of news that you need to know, and it's been emphasized earlier, that this new variant is more transmissible. It's somewhere around 50% more likely to be transmitted from one person to the next, which means that we still need to wear our mask. We still need to practice social distancing and wash our hands, et cetera, but we need to double down on that. And, because we want to keep this variant, as low as possible, and we don't want more cases because that leads to more hospitalizations and more deaths. So if anything, because of this variant, we need to do the things that we've been told to do and that we know we need to do. That is mask up, keep socially distanced, wash your hands fairly frequently. So if I could have the next slide, please. Now, if you're listening to the news, and everybody probably should be doing that, reading the newspaper on social media, you'll probably hear about some of these other variants. So I want to mention this one from South Africa, which the virologists call B.1.351, or the South African variant. Now, this has mutations too, and it even has some of the same mutations that the English variant has, but some different ones too. Now, let me emphasize that, okay, the slide is actually a little dated from today, because just this afternoon, we found that there was one of these variants, this particular B.1.351, that showed up in the US. But let me emphasize, how fast this is moving. The data on all this, it's not the prominent variant. And we hope that the B.1.1.7 is the one that's going to actually spread through the US. It probably will. It's already in many states. It's rare to see this variant, the South African variant, but we need to keep our eyes on it. It is more transmissible like the English variant. It's not more deadly. But one of the features that it has is it does seem to escape the immune system a little bit better. And so we need to keep an eye on it. We may need to tweak the vaccines a little bit down the line. If you've read the newspaper, you probably already know that Moderna, and I'm sure that the other vaccine manufacturers too, the Pfizers and the AstraZenecas, et cetera, are already working in the labs to modify their vaccines so that we'll be protected against this variant too. So somewhere down the line, after we get our 1 dose of the Janssen vaccine or the 2 doses of the Moderna or the Pfizer, we may see that we next year sometime get another dose of the vaccine, just like the yearly flu vaccines. And those new doses might be modified to protect against this particular variant. So one more slide, and then we'll be on to the general questions, I think. This is the other variant of concern, the so-called P.1, first detected in South America and Brazil. Same story, pretty much. It has mutations. Some are the same. Most of them are different. It was recently found in the US. It's more transmissible like the other ones, but not more deadly. So same thing. It does seem to have some immune escape. But again, let me just emphasize, if this is the variant that starts to take off, our vaccine manufacturers will be prepared for it. Vaccines will be modified, and you may have to get a booster dose next year to protect against this variant. So bottom line, the virologists, the vaccine manufacturers, they do have these variants under control. That's the good news. Don't let the people on the news scare you too much about the variants. We are keeping track of them, and we can deal with them. So thank you. I'll turn it back over to Dr. Kennedy.
Great, thank you very much. And thanks to all the panelists for the great information that you provided tonight. So we're going to open it up to the audience for questions. Now, we've had some questions, Q&A in the Q&A box, and some of them have been answered. But I do have a few that I think are important for us to discuss, because I know I've heard questions about this. Recently, we've heard comments about when to get the second dose because of the shortage. There were people talking about extending the time rather than the 3 weeks or the 4 weeks. And so the question is, do we need to get that second dose? And does it matter if we wait past that 3 weeks or the 4 weeks as recommended by the CDC for those for the Moderna and the Pfizer vaccine? So I'll throw it out to anyone who would like to answer that question.
I'd be happy to. Yeah, so ideally you want to try to stick to the schedule. And you do want to try to get the second dose. It's true that the first dose will provide you with some protection, maybe 50 to 80% protection after a couple of weeks. But when you get that second dose, it gets you up to that 95, 94% level, which is what we all want. The other thing is that the second dose might make your protection longer lasting. Okay, if you just get one, your immunity may wane, may fade, but with that second one, it makes your immune system stronger for a longer period of time. If you're a little bit late, it's probably okay. There's many other vaccines, hepatitis B and others, that people don't get exactly at the recommended time. Generally, it's better to get a little later than a little bit earlier. But if you're, if you're a few days late, it's more likely than not it'll be just fine. It just hasn't been studied in clinical trials, so we don't know for sure. But most likely, it will be okay.
I agree, and I think we should probably stick with the schedule. When you have clinical studies and you show a benefit, when you start to create new protocols and move away from what was studied, then we find unexpected consequences. And certainly with vaccine hesitancy being so high, especially in minority communities, any negative glitch may have the long-term problem of decreasing the uptake of vaccine in the future.
Great, thank you. Now, we also have heard, I guess, about Moderna making a booster. And this question is about whether you think that we will, like the flu shot, do you think that we'll have to get the COVID-19 vaccine annually after this, this period of time where we're trying to get everyone vaccinated?
Dr. Gary should take that.
Well, sure. I think Dr. Ferdinand said earlier that, there are some things that we are still learning about the vaccines. And so that's going to have to be evaluated as we go forward. We are hoping that the vaccine will give immunity for at least a year. And I think that all the data and evidence out there is that is going to happen. Now, will it last for 2 years? That's possible. But, we're going to have to get the data and find out. Will some of these variants that I mentioned earlier start to spread, and we might have to tweak the vaccine and give a booster shot with a slightly tweaked vaccine? That's also possible. But, we're in kind of a war against this virus. So we're going to have to, all pull together, just follow the guidance of our public health, trust in the doctors and the people that are giving you the information. They are going to do the right thing. The FDA, the CDC, they're going to tell you the right information, perhaps now more than ever. And, don't hesitate to get the vaccines. You need to do them. Don't let all the talk about the variants worry, or about, are we going to have to get it, in a year or 2 years? That'll all be determined in good time. Let's just all pull together. The vaccine, as Dr. Ferdinand said again, is our best way out of this pandemic, and we all need to get it as soon as we can.
Great, thank you. Now, this is an interesting question having to do with pregnant women and whether or not they are more susceptible to COVID-19 infections, and are their symptoms more severe? So does anyone have any information on that?
Dave, you're muted.
I can address it, I think. In fact, it was on a fetal medicine expert was interviewed on the radio. I think it was yesterday or this morning. So, the problem is, of course, that the studies excluded women that were pregnant. But what happened was, and this happens in many studies, it turned out that some women, after getting the vaccine, found out that they were actually pregnant, and they didn't know it, or they got pregnant soon thereafter. So there's a registry, there's a database that these women are in, whereby they can be followed. It's a very small number. I think it's maybe 24, 25. So far, they haven't seen any bad effects of the vaccines on the women or the babies, but it's too early to say. But, pregnant women, most do fairly well, but some can get sicker. And can have complications of pregnancy. Initially it looked like that wasn't going to be the case, but as the COVID pandemic has progressed and we've gotten better at understanding it, pregnancy, it's a fragile time for a mother because her immune system is a bit weaker, and so they can get sicker. And so all these societies, the American College of Obstetrics and others that are govern how we practice medicine in terms of taking care of pregnant women, recommend that that the pregnant women be offered the vaccine. Now, it's a personal decision between them and their doc or their provider. There may be some that don't want to. There's some pregnant women that are higher risk, perhaps because of various risk factors. So it has to be a carefully discussed issue. But so far, It appears to be safe in these women. We do need more data. And again, the risk of a bad outcome if a pregnant woman gets COVID has to be balanced against the unknown about the vaccine. And so I think that that's something where, one does need to have a discussion.
Great. I think that's very important to remember that we still have to practice wearing masks, social distancing, washing our hands. All of that's very important for everyone as we're going through this. So thank you for that information. Another question, what about children? I know that they have not studied children extensively yet. Any thoughts on that or any information on children and the vaccine?
Pfizer did go down to 16 years of age, and they're actually having emergency authorization for that. Moderna didn't have a substantial cohort in that age group, so their authorization is for 18 years of age. We know that children can get COVID-19. There are some cases isolated and somewhat rare, but where they can get a multi-system inflammatory disease and get quite ill. But in general, I would, again, stick with the science. The studies have not yet been in children. The emergency authorization is not approved for preteens, and I wouldn't use the vaccine in that age group.
But the good news is there are clinical trials that are ongoing now. They are recruiting children. The last I checked a week or two ago, they were having some difficulty getting people to participate, and that's understandable. Parents are anxious. Children are a vulnerable population when it comes to research. They need to be protected from unscrupulous research. So I think it's being, obviously it's being done very carefully. But again, we do need data. But one would, it's more likely than not that the vaccine will be effective in that population and will be safe. There's no reason to think that it won't be. But for right now, we do need to adhere to the current guidelines.
Dr. Kennedy, if I can make one more statement about children, you're hearing now in the media, and I think everyone has heard it's, quote, safe to go back to school, end of quote, and they're basing it on a CDC report. But again, you have to look at what the report was. It was a small school system in which they did everything right, socially distanced, had plexiglass up, hand washing stations, the children wore their mask. That doesn't mean you can go back to the good old days where you have children clustered in a room, no mask wearing, no hand washing stations, playing indoor sports without any protection. And somehow when that message got out yesterday or the day before, it sounded like school's in, everybody, let's go back. And that's not really what the study said.
Okay, great. That's great information. Now, this is an interesting question about those who've been infected with COVID and getting the vaccine. So the question is, are the side effects worse in someone who has had the infection and then vaccinated?
I don't think there's any good evidence to suggest that the side effects are worse if you've had COVID. I think Dr. Mushat recommended you wait at least 2 weeks if you've had a COVID infection to get vaccinated. You should think of it as a boost response to your immune system. So your body's already seen the virus, and that vaccine, that first dose that you get, is going to act to boost your immune system, so you'll be even better protected. But the clinicians can jump in here. I don't think there's any evidence to suggest that the side effects are that much worse, particularly if you wait at least 2 weeks.
That sounds like a reasonable recommendation. We know that the viral load has now decreased remarkably, where the patients are less expected to be able to transmit. So the immune response should be at a point where it could receive the vaccination. The CDC actually clearly states that persons who have been previously affected, if they're not having active symptoms, can receive the vaccine. Now, if you're sick, you're coughing, you're wheezing, you shouldn't get a vaccine.
Right. I think the recommendation is 3 months after the infection. You can get the vaccine. Right.
Well, you can get it earlier. I think what the CDC says is if you're wary about it, if you're not feeling well, it's probably safe to wait 3 months because you're probably protected by the COVID. But On the other hand, if many people after 10 or 14 days feel pretty good. And they've recovered. And so, if you get an opportunity to get the vaccine in 2 or 3 weeks, I would do it. It's probably more important to get it than to wait and figure out how you're going to get it later. But there's some leeway there.
Great, thank you.
There's been a lot of talk about getting the vaccine as soon as you can, and really that is great information. But there's some other things out there too that may be opportunities for people on the call, and that's participation in clinical trials, because there's going to be some new trials that are coming along. We'll probably have some different types of medications, therapeutics that can be given to COVID patients, and we need to be aware that if you do get infected, that maybe you'll want to participate in these clinical trials. And there'll probably be clinical trials of some new vaccines, because we have 2, we may get a 3rd and a 4th pretty soon, but it wouldn't hurt us to have a 5th and a 6th somewhere down the line. So if you can participate in a clinical trial, we'll need your help. And as I said again before, we're all in this kind of war against the virus together, and one of the main things that citizens can do is to participate in these clinical trials.
Great, thank you. This is an interesting question. If the vaccine, we know the vaccine was just developed and released in December, how do we know that you don't have long-term side effects from the vaccine? Because it hasn't been studied for a long time. So that's the question.
Well, in terms of the history of vaccines, we've never held a vaccine to the standard of, well, let's look in 30 years and see if it causes Alzheimer's. Or let's look in 40 years and see if the vaccine that I got as a child caused heart disease. Those are very difficult associations to make from a clinical epidemiological standpoint. So we've never held any vaccine to that standard. So in terms of trying to hold these newer technologies to that standard, it's unfair. And I would hope that Dr. Ferdinand and Dr. Mushat, just by showing you the statistics and showing you the data, COVID is killing people. It's killing our loved ones today, tomorrow, next week, next month. Let's not worry about 30 to 40 years from now. And remember what I told you, most vaccines that we've developed in the history of vaccination, serious adverse events don't present 10 years later. They present within 2 months. And we have that safety data now. There's no reason to wait. There's no reason to wait. You're not the first in line. We have the safety data. These vaccines are extremely safe.
Great, thank you. And I think we have time for one more question, and that has to do with the cost. I know that Dr. Ferdinand and I were in a meeting, the Health Equity Task Force meeting, and someone brought up the fact that a patient thought he or she had to pay for the vaccine. But someone comment on what is the cost of this vaccine?
Yeah, no one actually has to pay for the vaccine. They are asking for insurance information if people have it, but the vaccine is free. And I think the messaging is very, very important. And we're excited about this particular panel because people need to understand the relationship of the vaccine to every other drug. This particular vaccine is free, it's safe, and it will be available. And so when we're comparing, we have to compare apples to apples, oranges to oranges. When you compare the vaccine side effects and everything else like that, and the amount of time that they put into the vaccine and the data that's already been proven, I don't think that you'll find too many drugs that hit the market that has this level of safety and free.
Great, thank you very much. Well, thanks to all of you. This was excellent information, and thanks to the audience for participating and for submitting those questions. We really appreciate it. And if there are other questions, you can submit those to us. And let me see if we have specific information about that. We have a website, haltcovidla.com. and information can be submitted to us, or other questions can be submitted to us. So thank you all very much for participating. Have a good night.
Thank you, Dr. Kennedy. See you at the Vaccine Center.
Thank you,
Great.
everybody.
Thank
All
you.
right, thank you.
It's great.